Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is How Deprescribing in Psychiatry Offers a Path to Safer Care. Muhamad, welcome back to the show.
Thank you for having me to talk about this timely and important topic about deprescribing in psychiatry and the general deprescribing movement that's happening in the country, and just give the perspective from psychiatry and talk a little bit about the medical field also and what's been going on.
All right. Why did you decide to write this article? And then tell us about the article itself for those who didn't get a chance to read it.
So as a psychiatrist who's been in practice for more than 25 years, I have seen how the field of psychiatry, and as a board certified internist, how we have basically learned how to add medications. We can, for example, add one for sleep. We can add one for nausea to treat the side effects of another medication. If one medication causes weight gain, we add another medication to help with the weight gain. If antidepressants cause any side effects, we can add other medications. And so we have basically developed a vicious cycle of adding medications, and polypharmacy just became the norm in our society. And not until a few years ago where I just started kind of just challenging the status quo and starting to deprescribe in terms of my medications and in terms of my patients, and offering that choice to patients and talking to patients and to family about what's going on, why their loved one is on so many medications, why they are on so many medications, and basically start a planned and supervised reduction or stopping of medications that's safe, that is with an informed consent, that's evidence-based. And I think that the changes that we're seeing also in the healthcare system in the last year or so, I think just kind of gives more credence to that movement, because 1 in 5 or even 1 in 4 of Americans are on psychotropic medications, and we need to try to see how we can help them with that.
And in your article, you use the term prescribing cascade that describes exactly what you're talking about when more drugs are added to treat side effects of other drugs, right? How did it get to be this way? Why is it's so easy for physicians to just add on medications? Why do we come to this point?
I think a big part of it was that patients demanded it. We got into this cycle where we wanted to appease patients. Patients were unhappy. For example, if they come in to a visit and they're expecting an antibiotic and they don't get an antibiotic, or they come into a visit and they have a complaint and they don't get a medication. I think medication became the purpose of the medical visit, while counseling, lifestyle management, kind of talking about other things just kind of took a step to the side, and basically all we did was just prescribe medications. At least that's in my field in psychiatry. We just became prescribers of medications. We left therapy for the counselors, and basically we just had 15-minute med checks and prescribed medications. And not until the last 10 years or 15 years that we decided that also we could employ other treatment modalities, and that we are doing right now and that I've talked about in the past. But definitely we just became internists, psychiatrists, neurologists, other specialties. We just prescribe medications.
And other than the obvious fact that patients generally don't want to take so many pills, so many medications, especially psychotropic medications, it can lead to obvious patient harm as well, right?
Absolutely, absolutely. They experience side effects, and then what happens is we give them other pills, other medications to fix the side effects of the first medications. And so when you talked about a cascade, it's like a downhill slope where the result is not positive for the patient. I think what really kind of gave it to me, one of my mentors when I was at the National Institute of Mental Health at the NIH, Dr. Ezekiel Emanuel. He's a medical ethicist, and he's an oncologist. And he came out with a piece where he said, if he's above the age of 75, he no longer wants any aggressive treatments. No antibiotics, no codes, no cancer treatments. If he had lived to the age of 75 and he had a happy life, he just wants no medications, just limited treatments. So I think that, and a lot of clinicians says, well, what is he thinking about? It's like this is nonsense. But there are people who just congratulated him for that because a lot of patients heard that from a leader in the medical field, a medical ethicist who just says like enough is enough. We just have to figure out that at one stage we really can't just keep prescribing pills. And the average elderly person above the age of 65 in the United States is on about 5 or 6 medications. So we really need to figure out how we can help our community, our patients with deprescribing and specifically with psychotropic medications.
So tell us what kind of advice you have for physicians to determine whether they're in the midst or just starting one of those prescribing cascades you're talking about. How does a physician even know that's become an issue?
I mean, you can see it with basically just the routine continuation of prescriptions. When somebody is on 5, 6 medications, 10 medications, and when there is no identification of basically why is this medication being prescribed, what are the long-term outcomes of this medication being prescribed. An example is actually from my daily practice. A few days ago, I had a patient whose age is 75, and she's on a cholesterol medication. And I know you had talked with another physician about how cholesterol medications are being overprescribed. She's 75. Her cholesterol is borderline, but she is on a cholesterol medication. And I inquired to the patients, like, why are you on this medication? Do you know why are you? Well, it was just started by my primary care doctor. Well, this is an additional medication. She's also on a lot of psychotropics, so we're trying to taper off. And when I put in the question to the patient and she challenged her primary care doctor, the primary care doctor said, well, let's look at your cholesterol. So they checked the cholesterol and they said, well, it's borderline elevated, maybe some diet. Let's stop the cholesterol medication and see what happens. So these just are medications that get put on and just get forgotten. There's no reevaluation, not just even like an afterthought. It's like, what is this medication achieving? What's going to do long term? A cholesterol medication for somebody who's 75, the benefits are going to be seen in 5, 10 years, and they'll be 85 at that time. And so just kind of thinking about long-term medications, I think should be on every session when we see our patients, like, and ask that question of the patient. If you're unhappy about being on so many medications, think about what each medication achieves for you. And I've had patients who said, I want to stay on this medication. I don't want to discontinue this medication. Or patients who say, well, I don't know what this medication is doing for me. And maybe if we try to taper off safely and try to deprescribe, I think is very, very important questions to ask for our patients.
So, are there any specific classes of medications where you have to be a little bit careful in terms of deprescribing and maybe warn a little bit of a slow taper rather than stopping? So, tell us the specific medicines where we just have to be a little bit more careful in stopping.
So with all psychotropic medications, with antidepressants, anti-anxiety medications, mood stabilizers, antipsychotic medications, you really have to be careful. You really have to really dig deep into why is the person on the medication and what's the diagnosis and how long have they been on this medication, and are you going to anticipate any withdrawal symptoms when you try to taper off this medications. And sometimes, patients, when they're on these medications long term, they may experience very painful withdrawal symptoms. Some of these withdrawal symptoms may be actually life-threatening. So if somebody is on benzodiazepines, for example, long term, that taper process is very prolonged and can sometimes be very difficult for the patient and sometimes needs a lot of attention from the physician. Mood stabilizers, antidepressants, sometimes you taper off, for example, antidepressants that patients have been on for long term, and they are okay. We think even sometimes 50% of patients will be okay if you taper off an antidepressant. The other 50% may experience some withdrawal symptoms. Some of them may experience relapse in their depressive symptoms. and may need additional medications or other medications, or they may need other treatment modalities such as psychotherapy or transcranial magnetic stimulation. So there are other treatment modalities other than medications. But in terms of psychotropics, we need to be very, very careful with that. The other very important group of patients are pediatric patients. Basically, deprescribing in pediatric patients also needs a lot of attention, a lot of focus, especially with mood stabilizers, antidepressant medications, because children sometimes are on medications, but their brains grow, their diagnoses basically change. Sometimes they outgrow some of their symptoms, and a very careful evaluation is very, very important so we can deprescribe some of these younger kids, adolescents of medications that maybe have been started and now they've outgrown the need for these medications and need a more in-depth assessment of their needs for psychotropic medications.
So let's talk a little bit more about the pediatric population. More and more of them are being diagnosed with things like ADHD and are on medications for that. I'm seeing more younger patients on various psychotropic medications. What has the trend been over the last few years? And within the psychiatric community, what's the thought about deprescribing some of these pediatric patients and getting them off some of these medications?
I think there's a great momentum. We are seeing in scientific journals, and I referenced in the paper the American Journal of Psychiatry. They've started talking about deprescribing, both for adults and kids, that we are at a precipice because if we don't control this kind of escalating cascade of prescribing, we are just going to be starting to cause more harm than benefit to our patients. Now I talked in my blog that there are patients that will tremendously benefit from medications. So I would not deny somebody, a kid with ADHD who is on stimulants and whose school performance accelerates and who's is able to function better with a stimulant. So that's a life-sustaining medication. So that's not somebody that I would deprescribe, but somebody who maybe has had some outbursts, some had depressive symptoms, and they were placed on medication long term, and there's never been a trial to see how would they do off medications. So always a conversation about the diagnosis, how did they do on medications, and risks and benefits of medications, a discussion with the family. And sometimes the family would say, our loved one, our kid did very, very well on this medications. We want him to continue on this medication because the benefits are really significant. And then there are medications where you put a kid on and there is really no significant benefit from the medications. And those are the ones that you would target with deprescribing. And always whenever the kid is on a medication for longer than 1 year, there needs to be always an evaluation, a reevaluation of why are they on the medication and can we take them off the medication.
So in both populations, whether it's the pediatric population or the adult population, it sounds like we need a conversation with whether it's the pediatrics family or the patient themselves, whether they even want to deprescribe in the first place. Some patients I talk to, they don't want to fix what's not broken and they just want to continue being on their however many medicines that they're on. But I think, like you said, it starts with a discussion in terms of why they're on the medicine, whether they're happy with the regimen, and whether they in fact want to deprescribe in the first place.
And I think it's very important because this is not we basically need to start having these conversations because these conversations are not being conducted in exam rooms between physicians and their patients. Just medications are being renewed with really no set benefit from these medications. And sometimes, the compliance is based, I mean, we're medications, we're thinking that the patients are on medications. If a patient is on more than 7 or 8 medications, there's a strong likelihood that they're not compliant with some or the majority of these medications. So that should be also part of that discussion. Are they being compliant with medications, or are these just medications on their records? They're not taking them, and whether we should start deprescribing with these medications. So this should be a conversation with every patient that we see. Why are they on these medications? Can we see if we can taper off some medications? And can we have that conversation? And if the patient says, I like these medications, they're helping me, they're life sustaining, that gets documented. And kind of, if there are adverse effects to these medications, you try to manage these adverse effects.
We're talking to Muhamad Aly Rifai, internist, psychiatrist, and addiction medicine specialist. Today's Kevin MD article is How Deprescribing in Psychiatry Offers a Path to Safer Care. Muhammad, let's end with some take-home messages they want to leave with the Kevin MD audience.
I think we need an upgrade in terms of how medications are prescribed in America. And deprescribing really offers a disciplined way to reduce harm, to restore agency to our patients, and to rebuild trust between patients and physicians. And the work starts in the room between the patient and the physician. And I call on my colleagues, please start this conversation with your patients about their medications. I think we need to start this conversation in America. And I think the events that are happening around us in terms of the current administration are a good roadmap to being able to help our patients be on less medications and live a healthy life.
Muhammad, thank you so much for sharing again your perspective and insight. Thanks again for coming back on the show.
My pleasure. Thank you.